Okay, well, let's go ahead and get started. Well, thank you all for joining our first education call. It sounds like I'm hearing a little bit of feedback, so if you are viewing online and using your phone, just make sure one is muted so we don't have speakers and phone go. But I mentioned before we started, everyone's lines are muted. If you could push 6 or have questions, that's the best way. But that's really just to avoid any feedback and background noise for our presenter. And I'm very excited that we have Miss Debbie Cote on the line. She's part of the DPC Education Center's Advisory Council and has been a nephrology nurse for 31 years, so very well knowledged in the topic, of course. She currently works for the University of Virginia Health System as the administrator for their dialysis program, and was the past president of the Nephrology Nursing Certification Commission, is a member of the Mid-Atlantic Renal Coalition's Board of Directors, and currently the president of NRAA. So very active in the kidney community with patient care work, advocacy work, and education work. So I'm very excited to have her here today to sort of go over the ins and outs of dialysis. And Ms. Debbie, if you're ready, feel free to take it away. Thank you.
Thank you, Christy, for that great welcome. I do have to just say one thing. I sent that bio into Christy a while ago. I am now the immediate past president of the NRA, still very active in that organization, but a lot less responsibility at the moment. And I want to thank DPC for inviting me to share some of my knowledge with you all on dialysis. It's kind of a refresher for me. I am a nurse by trade in an administrator role, but the joy of that is that I'm able to keep our program very patient-focused and focused on the delivery of patient care. So today we're going to talk just a little bit about the principles, or just a little bit about what is dialysis. And many of you are probably on dialysis, maybe have been on for a while. So I'm hoping that maybe there will be some new information that we talk about in this session, and that you are able to still learn new things even though you might have been on for a while. So dialysis is the process. Why do you need dialysis? Well, when your kidneys fail, you begin to not remove fluids and not to remove the toxins and not to produce the hormones that your kidneys normally produce when they're working. And I'm sure you've all heard about your glomerular filtration rate and that magic number of either 15 or 10. And so your kidneys quit over a long period of time. And when that glomerular filtration rate, or your GFR, gets to be about 10 or 15, in that range depending on your symptoms, your doctor's telling you that you need to go on this dialysis or get a transplant, and that's the only way you're going to be able to survive. And that's absolutely right, and many people tend to try to deny that early on because it's just so frightening. But I can tell you, in my experience, there are patients that have been on dialysis now for decades. So what happens when you need dialysis? Well, you need to figure out what type of dialysis that you want. There's hemodialysis, which is where we get access to your blood and circulate the blood with a machine outside of your body and through a dialyzer or an artificial kidney, and then return it to you, correcting your removing the poisons, correcting your electrolyte balances, removing fluids. Peritoneal dialysis is a method by which you put a catheter in your abdomen, and you've got your belly and your abdomen in all of the pieces and parts, all of your stomach, your intestines, all of those things are held in place and held together by your peritoneal membrane. Just kind of holds everything there. And that peritoneal membrane can actually function much like your kidney does. And if you put the fluid into your belly via the catheter, it sits in that cavity, and the peritoneal membrane works much like that artificial kidney that you see on a dialysis machine, doing the same kinds of things. A lot of times doctors and nurses will tell you that peritoneal dialysis is a wonderful option when you're first starting dialysis because you have some residual function left. Your kidneys are still working a little bit. Not enough that you don't need dialysis, but enough that adding the peritoneal dialysis to it allows you to get some really good dialysis using that method. So how do you get connected? So for hemodialysis, there are 3 types of accesses. There's the AV fistula, the graft, and a central venous catheter. And if you listen to the tone of my voice, it went down when we talked central venous catheter. If you are just thinking about or needing to start dialysis, or if you have a catheter already, I'm going to encourage you that those are not to be permanent unless you have no other option. What those catheters are is they're inserted into a vein in your neck and then tunneled down into the right atrium of your heart. So if you think about it, the tip of that catheter is sitting right in the prime of your heart. And you know as well as I do, your body doesn't like foreign objects, and it's going to continue to try to fight to get that foreign object out. And that can create complications with your catheter where it puts a sheath around it, and the sheath is it's just like the body building this film trying to say get rid of that, and then the catheter doesn't work. It also gives a direct line from wherever that catheter goes in to your heart. And as you know, you can get bugs and germs and bacteria that enter and can crawl right down and get in there and cause a massive infection directly into your bloodstream. They are very susceptible to infection, even when your care providers provide excellent care. It's still a risk. And a lot of times patients think that it's a great option because I don't like needles and I don't want to get stuck. And this, I don't have to get stuck, but it really does put you at greater risk for infections. An AV fistula is, in the industry's words, is the gold standard. It is where your surgeon would tie one of your arteries to a vein in your arm, typically starting with your lower arm if your vessels are adequate, and then moving to your upper arm if you need one later. A lot of times you'd want to start in your non-dominant arm so that you're not using that as much in your dominant arm. So if you're right-handed, you'd want it in your left and vice versa. Under the high pressure of your artery, that vein thickens and becomes larger from the pressure. And if you've got one, you can put your fingers on it and you can feel what we call a thrill, and that's the buzz of the artery going through your vein. Takes about 6 to 8 weeks for those to get big enough and strong enough that we can cannulate them or stick the needles in them, the size of the needles that we need, so that you need to plan in advance. So if you're not on dialysis yet, your doctor needs to be talking to you about getting your access before you start. And even if you're not due to start for 3 months and it might go as long as a year, it doesn't hurt to get that put in right away. If you do have an AV fistula or a graft, you want to prevent anybody from sticking your arm for blood. You want to avoid restrictive clothing in that so that you don't impede the blood flow, whether it's below or above your fistula. You want to take care of it. You want to clean it on a regular basis. And you really should feel that fistula every day to make sure it's working. And if it's not working, you need to notify your dialysis clinic, or if you're not on dialysis yet, your physician as soon as possible so that they can set you up to have it repaired or declotted. A graft is used when your vessels might not be large enough or strong enough to sustain or enlarge the vein to make it big enough for the staff to get access to. And what a graft is it's a I can't even say PTFE. It's a long word. It's just a poly-type plastic graft that goes underneath your skin. Your surgeon would tie one end to an artery and the other end to a vein, and then your blood would be shunted through that graft. And that's what your care providers would access to get to your blood. So why do we recommend a fistula over a graft? Well, because fistulas tend to have less problems. Grafts can get narrowing. Well, they can both get narrowing on the outflow. So where the blood goes upstream towards your heart, the vessels can narrow. And what happens then is that it's kind of like a traffic jam in D.C. You get so many cars coming into one place, traffic gets stopped and you can't go anywhere. So when like you're going from 4 lanes to 2 lanes. So you get a narrowing in your fistula or your graft, then the blood's trying to get through and it gets that traffic jam and everybody gets stuck and then the blood clots. The blood clots more readily in a graft, and the graft is more prone to having those stenosis or the narrowing in the vessels. So typically they require more work. interventional radiology or from a surgeon's perspective. So it's recommended that you have an AV fistula first, graft second, and catheter last. Another type of catheter is the one I referred to for your peritoneal dialysis, and that one's the one that goes right into your abdomen, and then the tip of the catheter floats around in your peritoneal cavity, or right around like with your stomach and your intestines and things like that. That also requires that you take good care of it. Some people have gotten frightened about peritoneal dialysis because they hear of peritonitis. But if you follow your instructions, cleanse your exit site like you're supposed to, and take the precautions that the team teaches you when they teach you home dialysis, you can avoid those cases of infection. So if you're on hemodialysis, what are you going to expect during your treatment? You're going to go into your clinic, and the staff are going to expect you to wash your access with soap and water before you come to your chair. And if you can't do that, then your staff should do that for you when you sit down in your chair with some type of soap and water. And then they'll have usually two methods that they cleanse your access with, maybe chlorhexidine, which is a type of soap, or an alcohol, and they'll clean it for you. And then they'll identify the sites for which to stick the needles in, and then they'll cannulate you to gain access to your blood. Now, a lot of times patients are going to ask for numbing medicine, some type of cream or something that will stop the pain. Those can be used when your access, they can be used all the time, but it's preferred that maybe after you get stuck a few times and start building some scar tissue, that you don't use it, just so that you keep that skin intact and don't cause any damage to it or cause that skin to get any harder. I can tell you, if you've got an AV fistula, you will always feel the needle go into your fistula even if you numb your skin. And once your skin has scar tissue on it where they're cannulating you, there aren't any nerve endings anymore, so there's no pain there. So as much cream that you might put to numb your arm, you're still going to feel it when it goes into your fistula. So the team gets access to your blood. They'll use one line that they call an arterial line, and it's just the term we use. It's not really arterial because it's in your vein or in your graft, but the arterial blood will come from your body. Now, your heart could pump it, but it's not going to pump it fast enough. So if you look on your on your machine, you're going to see that there's a blood pump, and that blood pump is going to pull the blood from your body and push it through the dialyzer into the machine and back into your body. So you can see on the diagram, the green arrow takes the blood from your body, and then it goes over to that artificial kidney, and then you can see where those little yellow arrows are on your screen. Those are dialysate hoses, and your machine is going to take very clean water that your team has a treatment system in the back somewhere that they take good care of that removes all of the impurities from your water, and it's going to take a concentrate. You'll hear the staff refer to it as acid. It's not really an acid, or sometimes they'll call it a bath. And really what it is, it's a concentrate of electrolytes like sodium and chloride and potassium, and it's got a little bit of glucose in it, but it doesn't have any of your poisons in it like your BUN or your creatinine. It has bicarbonate in it, or CO2. And then what that bath does, it's got two hoses, and it goes in one side and out the other. So while your blood's going in from top to bottom or bottom to top, depending on how they've got your dialyzer and what lines they're using, your dialysate flow in that bath is flowing the opposite way. And what happens there, in chemistry terms, things are going to move from an area of high concentration to an area of low concentration. So when your kidneys don't work, it doesn't clear potassium. So when you eat foods that have potassium in it, potassium builds up in your blood. So when your blood enters the dialyzer, the concentration of potassium in your blood is typically higher than the concentration of potassium in the dialysate bath. And so it's going to move from your blood into the dialysate, and then it's going to flow out and down the drain. Conversely, your kidneys also maintain your acid base, so it helps to keep your carbon dioxide levels at the right level that your body would expect them to be. And what happens is, when your kidneys don't produce that anymore, you use that all up, or not all up, but you use some of it up, and your CO2 or carbon dioxide levels get low. And so your bath has a bicarbonate in it, and so in your blood, the bicarb is lower than it is in the bath. So the bicarb moves from the bath to your blood. So what it's essentially, all the work that's going on in that machine to do the work of your kidney is actually going on in that dialyzer. Everything else that happens with that machine are just other pieces and parts of monitoring and safety features. Your dialyzer is the critical piece. Just a side note, if you're on dialysis and your facility practices reuse, which means they take that dialyzer that they use on you, take it into a room, reprocess it, sterilize it, and bring it back to you for your next treatment, always make sure that you check that that dialyzer is your dialyzer and so that it's got your name on it so that you don't get somebody else's dialyzer. So the blood moves from the dialyzer and then it goes back out and back into your venous side. It's still your vein, but that's just, you'll hear the staff call it arterial and venous, and that's the venous is just typically the return into your body and to put the blood back in. Now it's important when you're placing needles that your arterial needle, or the one that we take the blood from, is located below the one where we return the blood to. Because if they're backwards, what's going to happen is as the blood flows back into your vein, if we're taking blood back out from above that, we're going to just take the same blood and recirculate it over and over. So that's something for you to watch to make sure that the blood that's returning to your body is closest to your heart, and that the blood that's being taken from your body is furthest away from your heart. So the dialysis machine is your care partner, and you should become familiar with it. I do like to encourage patients to be actively engaged in their care and ask questions. Sometimes staff appear to be very busy, but ask. They do enjoy talking, and it helps them verify their knowledge, and they love to share, even when they're busy. Keep asking those questions. It's your blood, it's your body, it's your life. So some of the things that you're going to see on that machine is going to be your blood pressure, and they should take that. Different facilities have different requirements, and sometimes it depends on the patient and how stable it is. Your blood pressures change. One reason is because we take blood outside of your body, so there's less blood in your body. The other thing is that we're taking fluid off of you. And in the body, about 1/4 of all your fluid sits in your bloodstream. The other 3/4 of your fluid sits in your tissues and in your extracellular spaces and outside of your blood vessels. So when we're trying to remove fluid during dialysis, your body's going to try to maintain that 1/4, 3/4 ratio. So we take it out of your blood, your body's going to try to push it back into your blood so it remains 1/4, 3/4. However, if you've got a lot of fluid on, or if your body doesn't respond fast enough, we can take a lot of blood from your body, a lot of fluid from you, and your body isn't pushing it back into your bloodstream as fast as we're taking it off. And that can cause your blood pressure to go down. And that's why a lot of times the staff will say, can you put your feet up? Because that helps the blood to move a little bit faster because you're helping it to get back towards your heart and moving. So keep your eye on what's happening with your blood pressure and how it trends, and it's especially important to let your team know or your care providers know if you're experiencing any dizziness or lightheadedness or you just don't feel right, because a lot of times you will feel your blood pressure dropping before it can even be registered on a blood pressure monitor. Another thing you'll see on there is when you come in and you weigh pre-dialysis, you will have what the team refers to either as a dry weight or a target weight. And what that is the weight that your providers and you agree is probably the weight you would be if your kidneys worked and you weren't holding fluid in. And what happens is we can't tell if it's been the holidays and it's been Christmas or New Year's or something, and you've had a lot of extra food to eat, and you've had all those sweet treats that people have and the cakes, and you gained a couple of pounds of fat, but we don't know that, and then we're going to try to take it off in fluid. That could cause your blood pressure to drop. and then your target weight needs to be adjusted. So when you come in, we weigh you, and the nurses will look and do an assessment. They'll look at your blood pressures. They should ask you how your appetite's been, good or bad. If you're not eating well, or you're saying, oh, I feel fat and I want to lose weight, and you lose a couple pounds of fat, then you could have a couple extra pounds of fluid. And we have to kind of try to figure out where's that happy medium, which is the ideal place for you to have a good blood pressure and not show signs of having extra fluid on you. And so it's important, they'll ask you if you've had any diarrhea, nausea, vomiting, because those are all of the things that impact your fluid status in your blood. And then what they'll do is they'll look at what your pre-dialysis weight was, what your goal would be for that day, and then they'll calculate how much fluid to remove. It is really dangerous to remove a lot of fluid at one time. If you think about it, if you've got, and you've all seen bags of saline, each bag of saline is 1 kilogram of fluid. So if you've got 5 kilograms of fluid on from the time you left till the time you came back, put 5 bags of saline on you and feel how heavy that is on your heart. And your body is trying to adjust all that fluid. And if in 3 or 4 hours your team tries to take that all off, your heart goes, whoa, what's happening here? And it's trying to adjust, and your body's trying to adjust, and it just causes your body to react, and it's called cardiac stunning. It's a little bit of an advanced thing, but it's just, bottom line is, it's really not good for you, and it's going to be harder on your body, and it's going to make you feel more poorly than if you have lower fluid removals during your treatment. They'll also calculate into your machine how long you're going to run, so you'll see how much time you have left. You'll see how much time, how much fluid you've removed, and how much fluid is left to be removed. The other thing your machines do, and a lot of times you hear a lot of beeps and buzzes going on, is that it monitors the pressures within your system. So when we put those needles in, as providers, we try to put them in the best possible spot right in the center of the vessel. But if it should poke through and go out a side of it, or put another little hole in it and the blood starts leaking, you all know that's called a hematoma, and it hurts. And we don't want to have that happen, and everybody tries to avoid it, but it can happen. It can happen if you move during your treatment, or you get caught on something when you're moving your arm. And the machine will alarm if those pressures change. So if it was your venous needle and you had blood leaking out around it into the tissues, it's going to cause some pressure on your vessel, and it's going to cause the pressure in your system to increase, and they're going to have a venous pressure alarm that goes off. Same thing with your arterial needle. If the arterial needle falls out, it's going to cause the arterial pressure to actually go up, because that's negative, but it's going to alarm and tell the staff. And that's why you're able to have one staff member take care of 3 or 4 patients at a time, because there are safety mechanisms within your machine that watches these things for you. But I do want to caution you about one thing, and your staff, if you're on dialysis in center, you've probably been told, please leave your access visible so that I can see it. And there's a very serious reason for that, and that is that the needle that we use to access your blood has a small enough port at the end that even if that venous needle were to slide out and just be sitting on the floor or sitting in your chair, you could be sleeping, your blood could be dripping down to your chair and onto the floor, and the venous pressure in your machine is not going to change, because there's still enough resistance of that blood going through that small needle. I know it doesn't seem small, but it is if you think of the size of the tubing. There's going to still be enough pressure in there to not change it enough to alarm the machine, to make the machine alarm. And it doesn't take long. You probably looked at your blood pump speed on your machine. You might say 300, 350, 400, 500. That means it's going at 350 to 500 milliliters a minute. That is over a unit to almost 2 units of blood every minute. And if your venous needle were to become dislodged and you don't get an alarm on your machine, and we can't see your access because it's underneath a cover or your sweater's pulled down over it, literally, and I'm not saying this to frighten you, is you could bleed to death in a matter of minutes. So when your team members and your staff are asking you to please leave your access open, I plead with you to please do that. It's for your safety, and that is extremely important. So what should you know about your dialysis? So the blood electrolyte levels. I talked briefly about potassium. Potassium, I'm not a dietitian, so I'm not the expert, but I do know things. Bananas, watermelons, cantaloupe, tomatoes, and potatoes are high in potassium. The biggest risk with potassium is that it's responsible for muscle contraction in your body. When your potassium levels get too high, it stops your muscle contractions. The most important muscle that you have in your body is your heart. And if your potassium levels get too high and the muscles stop contracting, your heart stops to contract. There are some signs and symptoms that you can tell when your potassium's getting high, but when you're experiencing those signs and symptoms, your potassium levels are high and it's dangerous and you need to seek medical advice. And that is typically, I feel so weak, I can't put one foot in front of the other. I can't get out of bed, I can't get up to my car, I need a wheelchair where I normally walk. I recently had a patient tell me he had all he could do to call 911 to come get him because he was so weak. So if you get to feeling like that, you really need to seek medical advice. And so when the team is saying, don't eat those things, be careful with those things, it really is because it does put you at risk. Now, phosphorus doesn't put you quite at that critical risk. And phosphorus is one of those things that you can get your phosphorus levels really high and you're not going to feel a thing. Not today, not tomorrow, not in a week, not in a month, probably not in years. But what happens is phosphorus is something that's in almost every food that we eat. So when we say you can restrict your potassium and you can eat low potassium foods and you can control your potassium with your diet, that's easily done. Phosphorus is much more complicated because it's in so many things at such high levels. And so you are frequently asked to take what we call a phosphate binder. And that is, you might have heard Renvela, and I'm not promoting any binders. You've probably heard Renvela or Tums or calcium carbonate or something of that nature. What those products do is when you eat foods with phosphorus in them, you take those pills either just before or just after you eat, and everybody's different as to how it works best for them. And they bind. That's why they're called phosphate binders. They take the phosphorus in your stomach and they bind with the phosphorus that you've eaten, and then they excrete them through your bowels instead of absorbing them into your blood. So if you've eaten your dinner and then you take your phosphate binders a couple hours later, that phosphorus is already absorbed into your blood. So what happens when the phosphorus gets high? Well, remember when I talked about fluids in 1/4 and 3/4 in your blood vessels and in your tissues, and the body tries to maintain that? Well, what happens with phosphorus is the same kind of thing. Your body loves to keep things normal. It doesn't want to keep things in disarray. It's got to be normal. So when your phosphorus goes up, your calcium goes down. Well, your body doesn't like it when your calcium goes down. Calciums are strong bones. You need that for your bones. So then it has your parathyroid hormone, a gland in your body, says, oh my God, you need more calcium. And it says, steal this calcium from the bones and put it in the blood because I can't have my calcium low. And that, when I mentioned that it doesn't happen, there are no problems happen one day, the next day, or in a month, or in 2 months, or in a year, if that process were to go on for years, where your calcium's low and your body's telling it to steal calcium from your bones to put the calcium back in your blood and make that a normal level, what's going to happen? Your bones are going to become very, very weak. And you will just take a step off a stair and you'll fracture a bone. It's that easy. You can cough and crack a rib. And that's why it's really hard as healthcare providers when we're trying to teach patients this, is to say you've got to do it now because you don't feel it and you don't know the effects and you don't see what the trauma is going to be to your body until many years down the road, and then it's very hard, if not impossible, to correct. So very important to try to maintain your phosphorus at normal levels. And in your facility, you should have a dietitian that speaks to you on a regular basis about all of these things. and helps you with your diet so that you can find foods that you like and enjoy and that still can help you maintain these levels where they need to be. Sodium isn't so bad for you except for one big thing, and that is it makes you thirsty. Sodium makes you retain fluids because if you eat sodium, ingest sodium, and all of us have done this, if you've had a nice big order of French fries with a lot of salt, a couple hours later you're going, oh, I could drink a gallon of water right now. And that's because when the sodium gets high in your blood, your body says, no, I don't like that high, I want it normal. So how am I going to do that? I'm going to dilute it. I'm going to put fluid back in there. So it tells, when your kidneys work, it tells you drink fluid. Even when your kidneys don't work, it tells you drink fluid. And then what happens? You drink fluid, and then you've gained a lot of weight in between your treatments. And again, even if it's not causing you immediate problems because you've got too much fluid on, over time, gaining lots of fluid, it's the rubber band theory with your heart. You come in for dialysis, we take that fluid off, the rubber band is free. And then you put fluid on, that rubber band gets stretched, your heart gets bigger, it's pumping more blood and more fluid around, and then we go on dialysis and it shrinks again. And if you take a rubber band, stretch it, relax it, stretch it, relax it, over time, that rubber band doesn't stretch anymore and doesn't snap back in place. And that can happen to your heart, and then it causes fluid to back up into your lungs on a regular basis. And so the reason that your dialysis team asks you to control your sodium is so that you don't get as thirsty and you don't want to drink as much, and it helps you to control your fluid volume. And then things with sodium is a lot of patients will tell me, I don't eat any salt. I never touch the salt shaker. I don't eat potato chips. I don't eat things that are high in salt. But in our society today, all of us, the salt intake in our diets is well above what we should take in. And that's even more complex for the dialysis patient. And so I encourage you to look at labels on food products. They're all labeled on the back. They'll give you the serving size per the container, and they'll tell you how much sodium is in each serving of that product that you're looking to buy. And I'll give you a personal example is my husband has high blood pressure, and one of the things he really liked to eat when I wasn't home to cook him dinner was Chef Boyardee raviolis. Don't ask me why, I'm not sure. But that was one of his favorite things. But that one can of that has more salt in it than he should eat in a day. And so he's had to remove that from his diet. And there are other things that your dietitians can teach you which things are very, very high, like hot dogs and such, that are very high in sodium. But watch the little things that you don't think. I've seen patients bring in those small Lunchable packs that have a little bit of meat and a little bit of crackers, maybe some cheese and such. And those things usually have a day's worth of sodium in one small snack package. So I encourage you just to look at the package labeling so that you know what the content is. Monitor your fluid intake between treatments. If you find that you're gaining a lot of fluid and you're not sure where you're getting it, I would encourage you to get a liter bottle of some sort and put water in it. And then when you have your cup of coffee, when you're done, pour that water out into that coffee cup and dump it. And then as that liter gets empty, it will help you monitor how much fluid you drink during the day, because sometimes we just don't realize what we take in. You don't realize you get up during the night and your mouth's a little dry and you just take a little bit of water, and if you do that frequently, it adds up. And there are also a lot of foods that we don't think of that have fluids in them, so puddings, jellos, things like that, that are fluid even though they seem to be solids. Serum creatinine, that's another one of your lab results. There's creatinine and blood urea nitrogen, and those are the two toxins. So creatinine is a byproduct of your muscle metabolism. So when your muscles work, they leave creatinine that normally goes through your kidneys and is cleared. And so when your doctors are looking at that, they're going to look in general what level your creatinine is. It doesn't really indicate your day-to-day dialysis treatment. And if you are a strong muscular person, you're going to have more muscle use, you're going to have higher creatinine. If you're a small elderly lady and very petite, your creatinine levels are going to be a little bit lower. I'm going to skip down to the urea reduction ratio because that is something that we look at in dialysis. Your urea is your blood urea nitrogen, or your BUN. And what that is, it's a byproduct of food metabolism. So when you eat and you break down your food, that's what's left that gets absorbed into your blood. It's the toxins that your kidney clears. And so that is diet dependent. And what we do in dialysis is we'll measure that. We'll draw your blood pre-dialysis, measure your BUN, and we'll draw your blood post-dialysis, and we'll measure your BUN. And that helps your team to determine if your prescription, your 3-hour, your 3.5, your 4-hour, 5-hour run is long enough to clear the poisons out of your blood. And that's really important because that's just one way that we can measure. There are other toxins that we are not able to measure, that we don't know how well we're doing that. So when your team is coming to you and saying, we need to increase your treatment time, you want to do that so that we get you back to that normal functioning kidney as much as we can, or as close as we can, with the resources that we have with our technology today. KT over V is a little bit more detailed. It's a very fancy calculation that I cannot do. I have some in an Excel spreadsheet. Most of them are done electronically in our medical records. And it measures your BUN and your fluid loss and your weight and things like that. But it's just a scientific formula that tells you, again, how well we're dialyzing you. And you really want your KT over V to be above 1.2, and you want your urea reduction ratio, or your URR, to be above 65. And when we say 1.2 and 65, that's minimum. Anything better than that doesn't mean you can do less dialysis. It just means that you're getting better dialysis. Oh, that's all I have on my slide. I do want to just, before we open it up for questions, I do want to just give you one more little tidbit, because this is something I mentioned earlier about engaging patients. You've probably seen about medical errors in the workplace, and the best thing that you can do to make sure that you receive safe care is to don't be afraid to speak up. Ask your team members when they come over, your providers, did you wash your hands? If you see them and they've got a pair of gloves on and you didn't see them wash their hands and put those gloves on, ask them if they've just put those gloves on and washed their hands before they did. If you know what the procedure is to clean your access or to clean your catheter site and you don't think they've done it, ask your team. I don't believe you've cleaned my access site, or if they're using a product that's supposed to be on your skin for 2 minutes before they cannulate your access, time it yourself and make sure it's 2 minutes. If they start to stick you before it's 2 minutes, say it's not time yet. Know what those procedures are. Don't be afraid to speak up. Question your team. Watch your blood pressures. Tell them when you think when your blood pressure is going down. Ask about your lab results. Ask them what you can do to improve them for your health and well-being. But in that clinic, leave your access open, ask lots of questions, and don't be afraid to question the performance of your staff. It's your body, it's your life, and you need to protect that for yourself. So, questions?
I have a question. This is Makini from Georgia.
Mm-hmm.
My question is that when they stick you, and the needle does hurt, and they've changed needles, so the needles I use a 15-inch needle, but the points are larger now because they went with more or less expensive needles. And sometimes I'm stuck by people and it doesn't hurt, and sometimes I'm stuck by people and I just almost want to jump out of my skin. But I've learned recently that if they pinch just above where they're going to stick you, just above your venous site or
Yeah.
just above your arterial site, the needle doesn't hurt as bad. Does that have any harm to your site when they're pinching you like that?
No, they're actually pulling it back and trying to make it more tight so that you can stick the needle in. And let me say that I have two comments on that. Is one, as we all know, any place you go, whatever doctor, nurse, some have a more gentle touch than others, and you can't explain why. Everybody's doing it the same way, following the right procedures. Some may hurt a little bit more than others. However, there's also another thing, is that your skin has nerve endings in it, and depending on where we stick, we might be closer to a nerve ending. So I might come in and stick you one day and it doesn't hurt at all, and I could come in and stick you the next time and it's going to hurt more because I'm closer to one of those nerve endings. So yes, you can pull the skin back and make it a little taut so that you can cannulate the needle, and sometimes that does help diminish the pain from the needle stick.
Thank you.
You're welcome.
Deb, I'm not sure if you saw online on the chat, Tony had asked why it takes so much time to remove blood waste.
Okay.
Would you mind going over that a little bit?
Nope. So if you think about your normal kidney function, from your dialysis treatment on Monday to your dialysis treatment on Wednesday, if you weren't on dialysis, my kidneys would be working for 48 hours. So now you're going to come in and you're going to have an artificial kidney on your dialysis machine, that dialyzer, and we've only got 3 or 4 hours to do what your kidneys would have done in 48 hours. So it's not that it takes so long, it's just that it's not your kidney and it's not functioning 24/7. So we're trying to do in 3 or 4 hours what your kidney would have done in 48 hours. And just being able to do it in that short amount of time, I hate to date myself, but when I first started dialysis, it wasn't unusual. Just before I started, quite actually, it wasn't unusual for patients to run up to 12 hours a day. And that, I kid you not, in order to it, because they didn't have the same dialyzer membranes and technology that they have today. So doing it in 4 hours, although it seems like an eternity to those of you sitting in that chair, it is really much quicker than what your kidneys could have done it in. And so that is pretty stellar in itself. And then the other thing, too, is that even if we get the poisons off, so maybe when I mentioned your KT/V at minimum is 1.2, but your KT/V is 1.7. But if you've got a lot of fluid to take, you can't take that off too fast. So sometimes you have to run longer. And even if it's not a lot of fluid, if your body can't tolerate fast fluid removal, sometimes you have to run longer for it to be more gentle and cause you less cramping and cause you to feel less washed out than what you might feel if you try to do that all in a really fast time.
Do we have any other questions? Feel free. This is your chance. If you push *6 or #6, that'll unmute your line. Or if you are online and you wanted to type it into the chat, I can always share it with Debbie, or she can possibly see it there to answer. So this is the time for questions.
Yeah, I have a comment. And this was in response to the lady that called before about you're explaining to her about the nerve endings. One thing that I kind of found that was kind of helpful is that they do buttonholes. And if you find that area in her access that doesn't hurt so bad, they keep doing it and make a buttonhole, so they'll go in that same hole every time. And so it makes it not hurt so bad because you get used to that stick in that same area. And they say it kind of helps preserve your fistula, but not sticking it all over, but just, yeah.
So that is true. A buttonhole is much like a pierced ear, and that there's a flap in your blood vessel, so it closes when you pull the needle out, and you open the flap when you push the needle in. So it's the same way of putting in your pierced earring. You need to really speak with your physicians about that. There's some controversy in the industry If you have buttonholes, you need to make sure that the scab from the previous treatment is completely removed and that it is thoroughly cleansed to avoid infection before you insert the next needle. And you're right, though, they do use what's called blunt needles with those. So you don't, instead of having the sharp needle, it's a kind of a dull-edged end needle because it doesn't have to put a hole in your arm. But you do have to make sure that you do very good cleaning with that to avoid any infection.
You're right. I actually just got over an infection that I had to have a series of antibiotics for it. But yeah, you're definitely right. We were trying to figure out what was going on and like what happened. So yeah, thank you.
Yeah. So make sure you clean that really good and get that scab out.
Might see me again here, and to the response about the buttonhole. My husband was also on dialysis, and he had a buttonhole, and the vascular surgeon gave him his buttonhole and told me that I was not a candidate for a buttonhole. So I agree with Debbie. There is basically a lot of controversy about that, but the vascular surgeons are basically the determinator of who has a buttonhole and who has a fistula or a graft. And, you know, normally when you begin dialysis, you have the catheter.
That's exactly right. I see in the chat box here, one of the things that you can do, I know I talked about a safe environment and to question your team, but the other thing you can do is you can do as much of your care in your dialysis unit as you would like to by learning. One of the things that patients can be taught is to cannulate themselves, and I know that seems scary. But a lot of patients like to do that. They will clean their own arm because they're very particular. You know you're going to follow the procedure as you're taught, and you can cannulate it, and then you know the pressure and you know how it feels. So that is something. A lot of home hemodialysis patients do that, and you can do that in center as well. I had a patient in the past, he would come in, he'd build his machine, he'd cannulate himself. He used to make jokes and say he was going to listen to his own heart with a stethoscope, but we still know that we still needed to do. But he would put himself on, he put himself on dialysis, and when he got done, he would take himself off dialysis. And so you can certainly discuss with your care team about doing as much self-care as you would like to. It's a very good way to watch the practices and to learn more about your dialysis.
Debbie, can you hear me?
Yep.
This is Jack Reynolds calling from Iowa, president of the board of DPC. I just want to say that I found your presentation extremely informative and very well presented. One little tip I'd like to tell patients. Nobody listens to me, but one little tool that I take to dialysis is a compact mirror. And even though if they cannot turn the machine enough so that I can check everything, the blood flow, the pressures, and so forth, I use my little compact mirror and I reach out and put it over in front of the machine, and then I can read everything. Of course, it's all backwards.
That's a very creative solution. I know there are facilities, and even amongst my team, some of my staff don't like the machines to be turned because they want to be able to see them, and others will turn the machine for the patients to face them directly. So it depends on your unit policy, but that's a very creative way to be able to have the best of both worlds. Great suggestion, and thank you for your compliment.
You're welcome.
Any other questions? Thank you so much. It has been an honor and a privilege to deliver this message today.
No, thank you so much, Debbie. If anyone thinks of questions after the fact, feel free to reach out. You can email me, and I can put you in touch with Debbie to see if we can answer your questions afterwards. But if there are no more questions, I think then we're good for the day. Thank you so much for joining, and thank you again, Debbie, for that great presentation.
Thank you all.